Okay, I'd like to welcome everybody to today's second webinar presentation. I am Michael Saltzman, and I'm the Director of Digital Products at BlueSky Bio. If you've been attending all these webinar presentations, you've probably heard me say the same thing again and again, but that's a pretty good sign that you have been attending. And if you haven't, then I'll just give a quick run through. We are continuing with our ongoing webinar series during this time period. You could stay up to date with our upcoming scheduled webinars at blueskyplan.com/webinars 2020 and via our Facebook groups, BlueSky Bio User Group and the Viral Dental Education Group. We're still updating the schedule as things develop, so please stay up to date and you'll see that we're adding different webinars, different speakers on different subjects. If you're watching this live, we'll be sending the CE credit to you automatically to your email within a week or two. If you're watching a recording, then just complete a short quiz and we will be able to send you the CE credit. Past recorded webinars are also available via the same URL, blueskyplan.com/webinars 2020. If you have questions during the webinar presentation, then enter them into the QA box and we'll address them towards the end of today's presentation. For this educational event, we have the pleasure and privilege to hear from Dr. David Veige. David lectures both nationally and internationally on all aspects of guided implant surgery and advanced restorative dentistry. He's the director of Smile Design Dental Laboratory, and he runs an implant-based practice, Smile Designs Implant Studio. Today, he will be presenting on the topic of prosthetically driven tissue-supported surgical guides for full-arch all-on-X implants, ready to print in 30 minutes. David?
Okay. Good evening, everyone. Evening for me in the UK, I guess afternoon in the US?
Yep.
Which is good. I hope everyone is staying safe, and I'm really honored to be able to present to you guys, bring my stuff home right into your living rooms so you can do some education and learn while everyone's staying at home and making sure the health service is taking care of the people that really need it. So that's great. So yeah, thank you very much, Michael, for the introduction. What we'll do today is I hope to get through a little bit on Fullarch guided surgery using BlueSky Bio. Also, kind of a little bit about my techniques and what I do about data gathering. So, you know, the initial assessment, the initial data capture to allow me a nice, smooth workflow through the BlueSky Bio planning. So first thing that we're going to do is I'm just going to go through a little bit about guided surgery, how things are different compared to kind of tooth-borne supported guides compared to fully dentureless cases, which we're going to talk about today, and utilizing the dual scan technique. So let's just go through that presentation to begin with. So a little bit about me. First of all, I originally trained as a technician, as Michael said, over in Toronto. In Canada, me and my older brother, Ivan Veige, Ivan set up a lab called Smile Designs in Guelph, our hometown. I later trained as a dentist in the UK, and I completed an MSc in implants at the University of Warwick. I'm currently doing a fixed and removable pros specialty at King's. So that's a little bit about me. This is my clinic and my lab in Harrogate. So I'm here currently right now. It's dark out right now. But this is where I am. So this is with full arch implant dentistry. For me, it's all about this one slide here. It's all about planning the future tooth position. I want to know exactly where that tooth is relative to the patient before I think about where the implants are going to be. And realistically, the only way I can do that is I have to know, first of all, where those teeth are. And if the patient comes in with a dentureless situation, there's no sense in my mind about planning where the future implants are going to be without first knowing this setup. I want to know where that future incisal edge is going to be, so then I can plan what type of restoration I'm going to provide, whether it be an FP1, FP2, FP3. So it's a simple concept guided surgery. We'll just go through a little bit about guided surgery and how it kind of is and how we do the workflow. Basically what we do is we use an STL surface, which is simply just a digital scan or digital representation of the patient. We plan our implant relative to our future prosthetic. And then we design a surgical guide relative to that STL surface, which has been aligned to the patient's DICOM data. And my goal is always to have a screw retain crown. I like screw retain stuff because it's simple. You know, it's simple to fit the screw retain restoration. It's simple to retrieve. It's simple to, it's relatively simple to make in the lab. So this is always my goal. So how do we get there? What elements do we need to allow us a guided surgery workflow? Well, the first thing is we need a DICOM, so we need a CT scanner, okay? A cone beam CT scanner. We need some type of impression of the patient, regardless if it's an intraoral scan or if it's an impression. Now, I personally use silicone and putty still. I like a medium body silicone and a light body putty. Oh, I got a question, I think, from someone here. Where are they? Is that right? Is someone raising their hand for me?
No, that's fine. People just,
oh, is that okay? Okay, fine.
like to raise their hand sometimes.
Fine. So I still use an impression, and predominantly why I use an impression is because I have a full team of lab technicians here with actually much better lab scanners sitting on top of their lab, on top of my lab benches. So I still take a putty and wash. But there's no issue whatsoever taking an intraoral scan at the same time as well. My favorite scanners are Trios and Carestream scanners. I use 3Shape in the lab, so accepting Trios scans works really well as well. So those are the kind of the three elements that you need to get to the next stage. And then of course, the common output files of these are STLs and DICOM. So we need these two types of files. DICOM comes from your CT scanner, and your STL comes from either your digital conversion of your poured silicone model via your lab scanner, or an intraoral scan using your intraoral scanner, okay? And then we put all that together using some type of software. Now, my preference of software is BlueSky Bio. I think it's, I need to say this as well. I have no financial backing from BlueSky Bio. I use BlueSky Bio strictly because I think it's the best software out there. It can do everything that I need, first of all. It is free to download and use. The only time when you need to start paying for anything with BlueSky Bio is when you're actually starting to export things. And currently, when you start paying for things is when you start exporting surgical guides or dentures. So when you've made a digital denture and you want to export that out. Okay. So let's talk about Fullarch guided solutions. So this is where we're planning a Fullarch restoration using implants, but we have no teeth to use as reference points. So we only have soft tissue. So we have a difficulty with merging the two, the DICOM data of the soft tissue and the CT scan of the patient. So one of the most common ways of being able to link the two together is to actually use radiographic markers, but not radiographic markers in the traditional sense where you use them kind of on the front surfaces of teeth to tell you where that prosthetic envelope is, but rather radiographic markers that are very specific so the two data sets can be linked together in the software. I used to use in the past, I used to use ball bearings. So 5mm ball bearings. Now, the problem with the ball bearings is they themselves produce scatter. So when you're stitching the two surfaces together, the two data sets of the ball bearings, the scatter on the ball bearings don't allow the stitch to be really, really accurate. So BlueSky Bio have come up with some really nice little glass beads, and they're 1mm glass beads that are stuck onto like a sticker. And you can use that on any of the surfaces that you want to use the radiographic markers on. I'll show you that. So the traditional way of aligning the STL surface to the actual DICOM data set is by choosing points, common points between the two. And when there's teeth, it's really easy. You just choose the cuss tips. But like I said before, we don't have cuss tips in the edentulous patient. We only have soft tissue. So we have an initial problem with aligning those two data sets. So when I get a patient in for the first time and they're edentulous, I've had many dentists come to me and ask me, what's your workflow? How do you go from start to finish with these cases? And a lot of my colleagues, the first thing they do is scan them. Well, actually, I don't really want to know what the bone volume is right away. I want to know actually where the tooth position is, because right when I scan them, I then have to scan them again to allow me to use my dual scan surgical guide procedure. So I'm actually exposing the patient twice, when really finding that initial bone volume doesn't actually give me anything that I need to know at that stage. So it's kind of a reverse way around looking at it. And what I actually do is I say, I kind of know already what's up there from my clinical examination. What I'm going to, and most things I can tackle surgically anyway, so I'm not worried about that side. What I want to do first is I want to first plan tooth position. So what I do is I go in through my full denture, removable prosthodontic stages right up to the try-in. At that stage, I then use that try-in as a dual scan. That then allows me to overlap the prosthetic envelope that I'm planning for the patient, and it's been approved by the patient, to then where the bone volume is. And at that point in time, I now have all the data that I need. I have the future tooth position, I have the bone volume. Now, if it so happened to be that the patient's bone is so terrible that I can't do the case, well, we've already gotten up to that stage. We then just continue down the removable prosthodontic stage. Now, it's an extremely rare scenario. In fact, since I've been placing implants for about 10 years, I haven't had a case where I haven't been able to do the surgery up at that stage. And even if I wasn't able to do the surgery, I would then maybe refer to colleagues that could. Let's say I wanted to send it down the pathway of zygomatics. I don't do zygomatics, so I'd send it down the zygomatic pathway. They still have all the data that they need. So the patient hasn't lost. We haven't lost. We've moved the patient along in the correct fashion. So yeah, this is the key. Don't place and pray. You know, plan where you want the implants to be relative to the actual future prosthetic. Being in the lab is an eye-opener. You know, originally being, you know, as a technician and working with my guys in the lab, is that you see cases and you think, where were they coming from? You know, they didn't have a final picture in mind, and the implants were just placed haphazardly, which then it's left up to us in the lab to kind of figure out how we're going to fix the case. So if you have an idea beforehand, you're going to get a better outcome in the long run. And for me, the big outcome and where I want things to be is I want this prosthesis to be able to be cleansable. And if you're placing implants in positions that are uncleansable for the final prosthesis to be made, let's say, for instance, they're very, very buccal in the upper anterior region, or they're outside of the keratinized soft tissue band, then, you know, these are things that you need to be thinking about beforehand, before the actual scalpel's picked up, okay? And this is what we're looking for. This is what we want we want patients that are coming in here because they don't care where the actual titanium is. It's only where the actual teeth are that they care about. They've come in for teeth, not implants. And Corey gave me this really nice slide here, and he not opened my eyes, but he was lecturing, and he was like, it really hit home. He's like, patients don't care about the metal bits. It's the white bits that they want. The metal bits are just a means to be able to hold the white bits there. So if we can get those metal bits in the right spot to hold the white bits, it's going to be an overall better outcome. And my clinical assessment for the patient when they first come in the edentulous manner is all about removable prosthodontics. Full mouth rehabs is all about old school prosto. And old school prosto hasn't changed in 150 years. So we start from the basics. You know, I figure out where my patient's teeth want to be. before we go to the next stages. And I use all these type of photographs. You know, I take photographs with patients with their bite occlusal rims in, because then I can relay that information over to my technician, who's going to be able to set teeth up in a better position than I would be able to if I didn't give them that extra information. That occlusal rim is a prescription, right? So I try to sculpt that occlusal rim as close to where I want that final tooth position as I can. And you know what, it might take me half an hour, 45 minutes to get that occlusal rim just right. But then when I get my setup back, it's going to be much closer to where the final tooth position is going to be. And all these changes, you know, we want to make sure we've got the right lip support. And we're going to have these edentulous patients that have severe atrophy to their alveolar ridges. So they're going to be needing proper lip support. And if you haven't planned that in the tooth position, first of all, and you plan your implants relative to where just the bone is, then you're going to have this overhang or this step, this cantilever. Now, is that okay? You know, yeah, sure. I mean, that's acceptable if you can't put the bone back, or, you know, you're only limited to that bone area, but you have to be aware of it. And I always mention to my patients that there's going to be this, or I try to augment it. Other landmarks that I'm using, you know, 2/3 retromolar pad for my lower occlusal plane. This is all information that the patient's giving me, okay? And this is what my occlusal rim looks like. When I've left my clinical stage, it looks like this. So I have a midline marked. I have my canine lines marked. And my canine lines, I use the medial campus of the eye and the ala of the nose. And the smile line. The smile line is really important for me, because what I'm 99% of the time, I'm trying to hide the transition zone of my Fullarch restoration with the lip. So if I know where my smile line is relative to the future implant position, I know that I want approximately 15 millimeters or more to allow me an FP2 or an FP3 style bridge. 15 millimeters would be kind of an FP1. And how we're deriving that value is, if you think of a natural central incisor, it's anywhere between 10 and 12 millimeters long. Well, if you take from the level of the implant shoulder to that future incisal edge, you have approximately 3 millimeters of transmucosal space, plus then the tooth on top of that. So if you have a 10 to 12 millimeter tooth plus a 3 millimeter transmucosal space, you've got a 15 millimeter restoration that's going to start from the implant shoulder to the future incisal edge. Then anything above that is going to be in our FP2, FP3 range. So I like about 18 millimeters from my implant shoulder to my future incisal edge for an FP3 style bridge. And that will give me a 3 millimeter occlusal band, soft tissue replacement, prosthetic soft tissue replacement. Okay, so after our occlusal registration stage is done, more clinical photos are taken, which then would allow us to, if we wanted to go down this road, is we could propose a digital wax up, a digital tooth position, to then allow us to visualize what that future tooth position might be relative to that patient. And this is a nice bit of a nice stage of the treatment where I can then bring this to the patient and say, what do you think about this? Do you like this tooth position? Do you want longer teeth? Do you want shorter teeth? Do you want narrower teeth? And all this is a staged procedure with the patient where I'm walking them through a restoration that they're going to have that is going to kind of grow on them a little bit, because they're allowing me to let them grow with it. If I just saw them and say, okay, that tooth position looks right, I'm happy with that, they've never seen it before. Once I deliver that restoration to them, sometimes they can be taken back from it a little bit. So I like this gradual stage thing. Now, the flip side of that is that you show them this, you better be able to deliver this. So that's the other side. So if you don't think you can deliver this kind of treatment or this look to the treatment, then you better be ready to be able to get sometimes pissed off patients about it. Okay. So these are those little radiographic markers. Let's talk a little bit more about the dual scan technique. So these little radiographic markers are on a little sticker, and the sticker is then stuck onto the actual denture, and the little glass bead is a 1 millimeter glass bead. And where I like to place these is I like to place them on this the buccal flanges of the 6, 4, 2, 2, 4, 6. And then I like to put them on the palatal side on the 7s, and then right in the incisive papilla on the palatal side. And the idea with this is you're creating external markers for the scanner to pick up in 2 different scans. The very first scan is with the patient in the scanner with their prosthesis in place and the radiographic markers in place. I like to also put them in a scanner where they have a chin rest on the scanner. And the purpose for that is if you have them in a bite fork type scanner, when they bite down on the fork, there's a tendency for them to bite on the anterior portion, which then can flip the denture down a little bit at the back. And if the denture is not sitting perfectly into the patient, well, then nor will your surgical guide or the reference points be made perfectly to the patient. And it could potentially tip it out of the way. So if you have a chin rest, there's no issue with that. And if they're fully edentulous, what I like to do is get them into the rest and then get them to bite together in occlusion. Yeah. And that is my very first scan. Right when I've taken that scan, so the patient's in the scanner with the radiographic markers in, with their denture in situ, scanned. I immediately take the denture out, and then I put the denture back into the scanner. And then I scan the denture as well. And what that's going to create is it's going to create 2 different DICOM data sets. Patient scanner with the denture in and the denture only, okay? This is what I was talking about earlier about the denture sitting on the bite frame. And what's happened, if you look in the lower right-hand side quadrant there, if you look at the blue outline, you can see it's raised off the palate. So what's happened is the denture has tipped because the patient was biting anteriorly on that bite fork. Now, if you didn't pick that up, you would go and fit your surgical guide, which the surgical guide would fit absolutely fine, but it would be in the wrong position relative to the patient. Okay. So another thing as well, if you've seen a patient and they've walked into the surgery and they have their own denture, and this is a denture that's been kicking around for 30, 40 years, and it's like socks on a rooster, it doesn't fit at all. Well, the fitting surface of that denture will be eventually the fitting surface of your surgical guide. So you've got to either decide, I'm not happy with that fitting surface, I'm going to start from scratch and make a whole new denture up to the trying stage, or I'm going to reline that denture because I'm relatively happy with the prosthetic envelope of it, but it just doesn't fit all that well. So these are decisions you need to be making when you see the patient for the first time. Okay, so what I'm going to do now is I'm going to flip through to a planning case. And this is actually one of the cases that I use on my teaching on the course, and it was given to me by Corey. It's a really nice case, which I don't believe it's actually one of Corey's cases, it's one of his colleagues. So we're going to go into the BlueSky Bioplan. And what I'm going to do is I'm going to go through the process of bringing in the 2 data sets, planning the implants relative to the future prosthetic envelope, creating a surgical guide. And then I'm also going to take out that denture and create an immediately loaded temporary prosthesis. And I'm going to do that in about 10 to 15 minutes, just to show you kind of how that works. So here's our BlueSky Bioplan. And this is the new version. I'm running this on a MacBook. So if anyone's got a MacBook, it runs absolutely fine on that. You can run a Windows system as well. They tend to update the Windows system a little bit quicker than the MacBook, but it's no problem. They catch up quite quickly. So how I like to start the case is I like to just I just simply drag and drop my DICOM data set. So that's actually a zip file. You don't have to unzip it, just drag it right on. And it'll load that file in for you. There it is. So we'll go through this case together. If anyone's watching this, you can record it. It's no problem at all, so you can look back at it. And what you'll see is the 3D render, you'll see a number of little dots here. And this is exactly as I was talking about before. This is the little ball bearing, the stickers with the glass beads on it, okay? So there's my first patient scan. And this patient was scanned with an upper and lower prosthesis in place. So the next thing we need to do is we need to now bring in the scan appliance, okay? So what we do is we go up to module here, and we've got a number of different modules associated with BlueSky Bio, which makes it extremely versatile. So we've got a crown and bridge module, we've got a denture module, which I use quite a lot to make my temporary prostheses for my immediate load restorations. And then we've got our surgical guide module, which is basically the nut and bolts of BlueSky Bio. This is where all the surgical guide planning stuff happens. And they've just added this new model editing and crown and bridge portions of the software as well. In order to bring in the actual next DICOM data set, we need to go into the model editing. And what you'll do then is flip over to File. And if you flip down here into Import DICOM, it gives you a list of different things that you can bring in. Now, I won't talk about all of this, but we want to bring in the scan appliance DICOM. And if you look at the little icon there, it looks like a denture with little markers on it. So it makes it really easy for you to find where that is. So you go into your scan appliance and you find the DICOM data set that is associated with this case. And we're going to bring in the lower denture scan. And there it is there. So there's our lower denture scan. And what the software is going to do now is going to take you through a sequence to allow you to align the two data sets together via those radio. Recognizes that the data sets between the two are common, and it actually links the two together. So what we're looking at here is we're looking at, on the left-hand side here, we're looking at the patient scan with the radiographic markers. This is the radiographic markers on the actual scan appliance. This is the scan appliance itself. And then this is them linked together. And what you'll see if I zoom in here really closely is you'll see there's a red and white ball overlapping each other. And that's these two surfaces overlapping. And the software's done it automatically for you. If you got into this software portion where the alignment is happening and you found that it wasn't aligning between the two accurately, all you would do is you'd simply come over to the corresponding marker, click on the marker, and then click on the corresponding marker between the two. And all you're doing is you're saying that marker is common on that DICOM data, and that marker is common on that DICOM data. Please align those two together. The software's done it already. It's that clever. Click through it, and what it's going to do now is going to put the two together. So what now you can see is you can see a denture, which is the scanned denture, sitting over top of the bone. Obviously, there's going to be a space because there's no soft tissue there. So now I've got a beautifully positioned and planned prosthetic envelope for me now to start putting my implants relative to this. One thing I like to do when I get anything in the BlueSky Bio, I like to change the color of it so I can see things a little bit more readily. So we're going to just flip on the color, change the color of the scan appliance to green. So if I now flip back into my module and go into my surgical guide and flip to an advanced mode, I can now see here very nicely the outline of my prosthetic envelope. And every now and then you'll notice there's a little bead here, and that's the little glass bead in the radiographic marker in the scan. And so I can check where they are, and just to make sure that they're nicely lined up, so that I know that the denture, the prosthetic, and the scan appliance is in the correct position. Okay, so let me start planning this case. So first thing I'm going to do is I'm going to redraw my lower dental curve. Okay, so start at the back, and I'm just going to start drawing it through kind of the middle of the mandible. Put a whole bunch of points through. Double click it and finished. Then I'm going to draw my nerves. So you can do this one of two ways. You can ask the software itself to detect the nerve, and it tells you how to do it. You say detect nerve, and it says please drop a point right at the opening of the mental foramen. So I'm just going to go and drop a point there and see what it does. Now, this works about, I'd say probably about 80% of the time. If it doesn't work, there's another way where you can simply take a single slice through the coronal section here, and you can then manipulate this single slice in and out to allow you to see the nice train tracks of the ID canal. Just for argument's sake, I'm just going to quickly detect a couple nerves on the left and the right, just so we know where they are.
Can I jump in for 1 second?
Yeah.
Not many users are aware that you could actually click on the entrance of the nerve in the 3D view itself.
Ah, okay. Oh, yes, sorry, yes. So let me do that again. Let me get rid of that. Surfaces, get rid of that. So another way of doing it, as Mike was mentioning as well, is you can just simply click into on the 3D render, detect the nerve, click into the canal here, and it will also draw it that way. So and that's quite useful, because you know those hollow mandible cases where there isn't a really well delineated ID canal. So, but there's always generally a mental foramen because it comes out of the cortical plate. So it's usually quite easy to then pick up the mental foramen as an exit in the 3D render, and you can see it there again. So if you just go and detect nerve and then click on that position, it will then trace a nerve backwards for you. Now, if I click out the single view, and there it is there, and we can travel back through the cross-sectional views of it as we move backwards. And that looks pretty good. Okay, so there's our mental nerves as they exit the mental foramen. Let's move to start adding some implants relative to our future prosthetic, okay? So here's our prosthetic envelope. So what I like to do is I like to get my first implant just on either side. And what I'm going to do here, just really simply, I'm going to add 4 implants vertically to allow for immediately loaded prosthesis, okay? So what I like to do is I like to then jump into my implant list here. There's a whole bunch of different icons at the top here. I like to keep it nice and simple here. This is all I really ever use up here. And really all I'm doing is I'm usually ever using is add an implant, draw my dental curve, add a tooth, or add a nerve. I sometimes want to measure things. So this is the measuring button. But other than that, that's really all I'm using. So there's only 4 or 5 buttons up here that you really ever need for the basic stuff. So go add an implant. We've got a full list of, almost you name it in an implant in here. Now, if the implant isn't in here, and I'm an OSTEM user, so my implant actually isn't in there, you can just simply make a custom implant, whatever dimensions you want. So a common implant that I like to place is a 4 by 10 millimeter OSTEM. So it's a 3.7 millimeter apical dimension, 4 millimeter occlusal dimension, 3.7 apical, and 10 millimeter long. And there's that implant sitting at the end of my pointer. So what I do is I just drop it into the position that I want. Now, once I've got that implant in the position I like, I always add an abutment. And the purpose behind adding the abutment is that I want to see where my future screw axis is going to be. So I made a common mistake here. I didn't choose the implant in the right arch. You must choose it so it's in the mandible or the maxilla. So let's just replace that. And what I'm going to actually do is I'm going to select a specific implant, because I want to be able to show you how you can add different type of abutments on there. So let's remove that. And we're going to add another implant. So let's add a BlueSky Bio implant. Where is it? Come in here, custom kit. Okay, so let's add it. Let's add a conus, which is actually a Astra replica, and I used to place Astra. So we're going to add a 4mm by 9 in here, okay? And make sure we click on the mandible so the orientation of the implant is in the right position. And now let's drop it in, okay? So once I got that implant in that long axis of my screw retention in the right spot, and I'm happy with it, a really easy way of actually replacing this implant or multiplying is if you right click on the implant and just duplicate it. And what you'll see is there's two implants overlying each other. If you drag one across, you can quickly align the next implant relative to the other implant. And they will be perfectly parallel in their duplication. So that implant is perfectly parallel to the implant. And all I've done is just dragged it across the midline. And what I'm going to do now is just simply position a couple implants here relative to kind of where my tooth position is. Now, as I was saying earlier, you know, my implant position, I kind of want this to come through the cingulum area. I don't want it to be too far palatal, because then my prosthesis is going to be really, really thick. So you've got to kind of position this in the right position so it's sitting and coming through the kind of the cingulum area, okay? So same thing with this one. I'm going to do the same thing on the other side. I'm just going to reposition this, replace this for one that is a mandibular implant. I think I've messed this up already. Replace that. Okay, and now I'm going to position this so it's kind of sitting relative to the cingulum position, okay? Then I'm going to simply grab that one. I'm going to duplicate this one again. Duplicate. And then I'm going to drag that across. Okay. So now I've got the third of the four implants in position, and I'm just going to start aligning this relative to the occlusal surfaces. Okay, I'm going to get this close. I'm not going to get this dead on. And then again, we're going to duplicate this one, and then I'm going to drag it across again. Okay. And then I'm going to just align this relative to the occlusal surface. Okay, so now I've got my four implants in position. Now this is the stage where I'm going to lock all my implants because I don't want them to move. And I'm going to now decide on what type of surgical guide kit I'm going to use. Now I use an Ostem 1 guide kit, which has a certain dimension of the drills. They have a built-in key, so there's no handheld key. The key is automatically built into the drill, which means the offset on each of the drills is exactly the same. And that offset for Ostem is 10.5 millimeters. Okay? And then the outside guide tube diameter is 5.5 millimeters to accept a sleeve. So if I'm going to, and what I do is I put the BlueSky Bio sleeves actually inside my guide tubes. So it's a 504 sleeve, and my guide drill is actually a 5 millimeter diameter, which means I only have a 0.04 tolerance between the drill and the actual guide tube itself. So they're really, really snug. There's not much give in them. There's not much tolerance in them as well, which increases my accuracy of my drilling sequence, okay? So when I put a sleeve in, I have to reduce this, the guide tube, I got to reduce the height of the offset by 0.5 because there's a 0.5 sleeve lip on it. So this will then be 10. So there's my setting for that. If I turn that on for all of my guide tubes and apply all, what you'll see is you'll start seeing some little tubes here. Let me just turn that surface off. There's my guide tubes I'm going to incorporate into my surgical guide, okay? And those all have that setting. There's a 10 millimeter offset from here to here. And this internal diameter of this guide tube is 5.5. And that's what my printer tolerance is going to allow me to place a 5.04 sleeve, which is just the name of the BlueSky Bio sleeve that's going to sit inside there, okay? So once that's all done and I'm happy with that, the next stage is I'm going to now convert that scan appliance into an actual surgical guide. So we're just going to go into our guide panel. And what you'll see here is you'll see with the scan appliance on, you'll see that this little create scan appliance guide has been, highlighted. If you click on that, it's going to start processing the data and now incorporating those guide tubes into the actual scan appliance. Just give it a second to do that. So if you go back into your surfaces panel, what you'll see is if you turn off one of them, you'll see now you have the denture fitting surface that was the scan appliance has now had incorporated into it the actual scan appliance with the surgical guide elements to it. Now, if you don't like this little bit here, that's fine. I actually like to keep that bit because what I do is I often add pins, which you can add in to help stabilize the guide onto the actual patient. And in order for me to orientate this lower guide onto the patient in the first instance, I often get them to bite together in occlusion because they were scanned in occlusion. And if I have this anterior portion to it, it allows an anterior portion, so like a tripod for them to be able to bite into. If you don't have that, then what you could do is you can make a lab silicone key, which would then fit over top of that, which has been, had mounted models in a dinar or something like that, that you can then make a key with the surgical guide. But I like to do it this way. So I hope that when this surgical guide is created, it leaves some of the anterior occlusion, so I can then have kind of 3 points of contact to allow the patient to bite the opposing dentition into it, position it in the right position, and then pin it in position so that the surgical guide is nice and stable. So I'm going to just quickly walk you through how I would then take this data and then make an immediate temporary prosthesis. So there's my surgical guide. I'm going to drill through these sites, place my implants fully guided. Now, to make a very simple and very easy immediately load temporary prosthesis, I'm going to simply go and export some of the stuff that I've created. So if I go into export data, I'm going to burn some money on you guys here, okay? So I'm going to go and export, first of all, just the scan appliance. So without the holes in it. So I'm going to go and spend 18 to 20 pounds, about 20 pounds for an export, 20 pounds burned for you guys in the coronavirus times. Yep. So there's my scan appliance. And then I'm going to also export the abutments, okay? So just the 4 abutments that are coming through. So we're going to export that as well. So abutments. And I'm going to then bring that stuff into a software called Mesh Mixer. Now, Mesh Mixer is simply just an STL editing software, okay? I use it quite a lot in my Fullarch guided stuff to manipulate, cut things, create interesting guides. So there's my 4 abutments, yeah, and then there's my scan appliance. Okay, So I want to make these holes in the scan appliance exactly where my future implant positions are going to be. And that's what these abutments are, okay? So all I'm going to do is, first thing I'm going to do is I'm going to make these solid. I'm going to make these abutments solid. And sometimes this happens. Sometimes it gets rid of a couple of them. If you just modify the accuracy of the solid accuracy, you can play around with it sometimes. Doesn't always get them all. Sometimes it works, sometimes it doesn't. Okay, there you go. There's 4 of them. Okay, so there's my 4 abutments. And what I'm going to do now is I'm going to ask the abutments to be deleted out of the denture. Okay, so I'm going to click on the denture. I'm going to click on the abutments. And it's something we call a Boolean difference, so a subtraction. And what it does is it creates perfect holes exactly where my future implants are going to be. So in real life, if I was going to do this surgery would probably take me about half an hour in total. I would provide local anesthetic. I would place my surgical guide on, first of all. I drill my osteotomies. I then place on my multi-unit abutments. I place on my temporary cylinders. And then I'd place this sat right over top of my temporary cylinders. I'd loop this all together, loop the temporary cylinders onto this prosthesis. And then I would lute it on. I'd take everything off. I'd close the surgical site. And then I would take that aside to the lab. And then I'd convert that to an immediate load prosthesis. So I'm going to show you that. I'm going to show you a case now where I've done exactly that. So we go back to our webinar. This is a case that I posted on Facebook before, but I'll just kind of show you how I've gone through the process of doing this. So here's the patient in their initial situation. And what we can see is the patient's been kind of like this for quite a number of years. And what's happened is the patient has had an excess of alveolus, which has grown down due to the edentulosism for so long. Now, if we were just to simply take those teeth out, place implants relative to that position, what would happen is we'd either have to make very, very short teeth, which would then weaken the actual prosthesis because we need a certain amount of thickness in it to allow strength. And also we would have a transition line, which would be on show because the patient has a relatively high smile line. And I don't want any of those things. So, which means that we have to plan where that future tooth position is relative to where the future implant position is, which means that we then are going to have to provide some bone reduction, okay? So here's the case, and this was actually done by one of my prosthodontic friends. I actually never saw the patient before I did the surgery. I just rocked up with all my surgical guides, ready to do the surgery. So the prosthodontist planned that this was going to be the future prosthetic envelope. And what he did is he did something really clever, is he actually kept open this palatal area. And it gave me 2 sets of information here. It gave me one, that the patient's prosthetic envelope, but it also gave me reference points on the inside. So on the actual patient. And I could use those tooth positions to align my, my soft tissue surface, which is relatively also roots as well. So I had soft tissue and roots. So this is the DICOM data. And what you'll see is the patient, as we move to the anterior portion, you'll see the patient has piles of bone, absolutely piles. So through the sinuses here, the little radiographic markers are actually the radiographic teeth in this situation. But look at the piles and piles of bone this patient has. So what I've done from this is I've figured out that my future incisal edge is at this point at the bottom X here, so this X position, and my implant shoulder is 17.36 millimeters away, which means that I want to take away 10.64 millimeters of bone to allow me to have a 17 to 18 millimeter height of prosthesis, okay? And that's that position there. So that's that tooth position and the radiographic marker relative to that tooth position, and then also relative to that root. Okay, so here's my implant planning. And what I then do is I create a number of surgical guides, which are going to allow me to do a number of different things. And the key to all of this is that the pin positions, all of my surgical guides are made reference back to that original pin position. And that's these little pins here that are sitting on the outside of the, Michael, how can I create a little pointer?
Try moving your mouse. Let's see if we could see it.
I can move it, but I can't see it.
I think you should have sketching capability.
Annotate. Let me try this. Yes. I see. Oh, that didn't work either. Okay, that's fine. So the little pin positions, which are the tubes that are coming along the side. So so how I approach this case is I provide local anesthetic, so buccal infiltrations, and then I give greater palatine blocks rather than palatine infiltrations. And the purpose of that is I don't want to blow the palate up so that my surgical guide then doesn't allow me to sit in exactly the right position, because this first guide is the most important guide of all the sequences. If this guide is in the wrong position, it means my pin positions are going to be in the wrong position. And if that's wrong, then all other guides are going to make reference to that will be in the wrong spot, okay? So nothing's done surgically yet. I've only given local anesthetic and I've put this initial guide in. And what I'm going to then do is drill my pin positions wherever they are, okay? Then I'm going to take that guide off. And this is how I plan it in BlueSky Bio. And then I'm going to then raise my flap. And these type of guides, you need to raise a big flap. And Corey likes to say that you raise a flap to the patient's spleen, all right? So if you're not a fan of flap surgery, this isn't kind of surgery for you, okay? So you raise a big flap, and you have to get the palatal flap out of there, because this next bit of guide, or the bone reduction guide, is going to sit into that palatal region. So get the flap out of the way, pluck all the teeth out, and then the next guide is going to make reference to those original pins. So I'm going to put this bone reduction guide back on, and it's going to be pinned into those original pin positions. Then you take the weapon of choice and you take the bone down. Now, I like to use a number 7 carbide. And the reason why I like to use it is it's quite efficient, and I can run the non-cutting edgeless shank on the surgical guide. You can see kind of, I just got the shank of the burr on the non-cutting bit right on the guide. So I can just make a really nice level cut across the alveolus. And you've got to kind of be quick to do this, because you know, if anyone's into Fullarch dentistry, you know you've kind of got local anesthetic time. So if you're not moving this quickly, you're going to run out of time. So yeah, so you kind of got in there, get that bone off. You can use rongeurs, you can use a piezo, you can use whatever you like. I like a number 7. Okay, so cut all the bone down, and there it is. Drill your osteotomies with a guide that's referenced to the original pin positions. Make all the holes, and then place your implants. Now, this next bit is, for me, probably the most important bit, is that I want to be able to make a reference to where my future immediate load prosthesis is going to be as well. Drilling all the holes is fine. But if anyone has conventionally converted, let's say, a denture to immediately loaded immediate implants, you're always kind of manipulating the denture in position to the patient, and it's never just right. You know, it's never exactly in the right position that you future planned it. Well, what about making a reference of that future prosthetic to the actual patient via the first pin positions? Okay, so what I did is I waxed up myself. So these are actually the teeth that are in the BlueSky Bio software. So these are the digital versions of my own teeth, re-waxed up again, and then I cut all the dies out and then scanned them so they could be used in the software. And then I digitalized myself, and I overlaid my teeth relative to the patient's future plan, because the patient said she really liked my teeth and wanted to have them. So I said, okay, fine. I'll see if I can get you my teeth. So I need to then create clearance for the temporary prosthesis relative to where the future bone reduction is. So this is my bone reduction guide, which is in blue. And I know that I usually have about 3 millimeters of soft tissue space. So I make that clearance to allow the prosthesis to sit there. Oh, am I frozen? Oh, let me come out here. Something's happened. Michael, can you still hear me?
Yeah, I can hear you.
Okay. Something's frozen on me here.
The video's fine as well.
Okay. I can't click out of. Can't click to the next slide for some reason. Oh, there we go. There we go.
Okay.
Yeah, okay, great. So then I use the same process that I just showed you in Mesh Mixer. I have my temporary prosthesis, and then I use my abutment deletion technique, and I create the holes to allow my future implant position to be sitting relative. Okay. This is one of the ways that you can link the two together. And again, it's just another Mesh Mixer thing where you have these kind of little balls and you can grow the balls up into the actual prosthesis. Skip through this a little bit. So I mill the temporary prosthesis in PMMA, and then I 3D print the surgical guides. Now, this is quite an old case now. But what we do is I actually 3D print everything. So we use, I actually have a frozen printer that I print most of my things with now. So this is a temporary prosthesis. And basically what I do is I just pick that thing up off the side of the bench and I sit back onto that original surgical pin positions. I loop that on and then I take off the little feet that are in between. And then I close my surgical area and I bond that in. And then that will be the patient's surgical, the immediate load temporary prosthesis for the duration of the healing phase. Now, when I first started doing immediate load Fullarch dentistry, which was probably about 7 or 8 years ago, I used to leave the patient a full 3 months to integrate. I don't do that anymore. I almost immediately start converting the patient into their final restoration. I have so few failures associated with Fullarch dentistry at the integration phase that I go right away to the kind of the healing stage. The only thing that I'm waiting for is actually the soft tissue maturation. Okay, and there's the before, and then that's the 1 week post-op. And it's an interesting case, this one, because you can see there's a little bit of a midline shift to the patient's left. And when we look back at it, I don't have the photo of it because the patient didn't want me to use her head photo, but the prosthodontic planning at the beginning didn't have the midline correct. So I followed the prosthodontic planning and it actually had the midline discrepancy. And I just followed that thinking that was the right position. Obviously, I run courses on BlueSky Bio in the UK. My lab is one of the only certified BlueSky Bio labs. We're not going to be able to run any courses because of coronavirus, but I'm happy to help anyone along the way if they want to get into surgical guide stuff using BlueSky Bio. Just drop me an email. Hook me up on Messenger. More than happy to help out with you guys. You're going to have a lot of downtime to be able to do stuff. So if you want any help or any advice, I'm more than happy to do so. That's it.
Very good. There are some questions that came in. Can you hit the Q&A on the bottom of your screen and maybe?
Yes, got them. Yep. So start at the top here. So which impression material do you use for Fullarch cases? Yeah. So I use a putty and wash material, and I use a 3M material. I can't remember the name of the actual material itself. But what I do is I basically do a two-stage impression. So I first of all put my putty inside the impression tray. I use a spacer inside of that, which is, you can get the preformed spacers or just cellophane cling film. Seat that into the patient, quickly take that out before it sets, take the spacer out, and then I use a light body inside of that, and then seat it back into the patient to allow that then to set together. It's kind of like a classical Invisalign impression. You know, that's kind of the way they ask Invisalign impressions to be taken. So I use it that way. Okay. Any tips? Next question. Any tips on how to take an accurate scan of the edentulous arch? I often struggle with this as a scanner finds it hard to distinguish sea of pink. So Mohammed's asking about using intraoral scanners to create an accurate scan of an edentulous arch. Now, yes, you can do that. The problem with that is you're simply picking up the soft tissue of the actual patient. Now, that's fine if you want to make a surgical guide which have implants planned with no prosthetic envelope. My technique, I use a surgical guide to allow me to show, a scan appliance to show me the prosthetic envelope relative to the patient's bone. But if you wanted to do it that way, not have a prosthetic envelope, use like little composite dots on the palate or on the soft tissue ridge. And what it'll do is it'll allow, or little zigzags along the ridge with flowable composite. And it'll allow the scanner some common points to be able to pick up as you're scanning around the ridge. Okay, I think that's helped. In your period, so next question, in your opinion and experience, how accurate are tissue-borne guides using a dual scan technique versus bone-supported guides? Yeah. So if you look at the data goes in accuracy of surgical guides goes tooth-borne guides, bone-supported guides, soft tissue-supported guides. Now, in my experience, bone-supported guides in the maxilla are not as accurate as a well-fitting soft tissue guide in the maxilla. And it's for this, and my belief is this, is that the segmentation of the maxilla is much more difficult to create that nice bone STL because it's so porous. And what happens is if it's porous and you've got an undulated maxilla, you're kind of anticipating where the bone's going to be. Well, if you get it wrong, then the surgical guide is riding on something. It's very, very difficult at the time of surgery to figure out what that is riding on. In the lower arch, because it's so well corticated, you get such a nice bony segmentation that the surgical guides in the lower arch fit lovely. So very different scenarios in the upper arch and the lower arch. The difference also is that when you have to fit a bone supported guide, you have to surgically remove all the soft tissue out of the area to be able to fit the bone supported guide down. If you do a poor job of that and the soft tissue is impinging on the surgical guide, you often then don't know it is doing that because you might just leave some tags or you might not actually relieve everything perfectly to allow that to fit down nicely. So in the upper arch, I like soft tissue supported guides with a nice palate on it that's sitting onto the hard palate. In the lower arch, I prefer a bone supported guide for accuracy. And then of course, above all of those is always a tooth supported guide. Okay, question FP. I think you're referring to FP1, FP2. These are MISH classifications on the amount of pink showing on the prosthesis. So an FP1 is essentially just tooth, so there's no pink restoration on it. FP1 is, I can't remember exactly the amount, is a small amount, and FP3 has a certain more, a greater amount of pink showing on the actual restoration. Most of my Fullarch dentistry is usually an FP2 or an FP3, generally. Again, just going back to it's a niche classification on the prosthetic element of a Fullarch case. Okay. Where do I get these glass? Next question is, where do I get these glass bead markers? BlueSky Bio. So just find your distributor, whatever country you happen to be in. If you're in the UK, you can get them from the lab, or you can get them from BlueSky. BlueSky is a UK distributor of BlueSky Bio components here. Just give you an idea on cost, I believe about 100 of them is about £100, but they are worth their weight in gold. They're so easy to put on. The scanners pick them up so beautifully that the stitches between the two, it happens automatically. So it makes your workflow a lot easier. Okay, what CBC scanner for spec? Yeah, good question. So most of my scans are done with a Carestream scanner. Now, a Carestream scanner has a specific scan appliance setting, which you go in, and what it essentially does is it turns down the voltage, or so there's not so much X-rays getting at the scanner to burn it out. Now, if you look at a lot of the older scanners, they don't often have that special setting, but they sometimes come with an X-ray attenuator. So it's like a little coffee can that you put over top of the actual denture, and it just slows down the X-rays getting at the denture, because the denture itself is actually relatively radiolucent. And if you throw a bunch of radiation at it, it's just going to burn it out, and you won't pick up anything in the scan. So the common a Galileo's machine has that kind of coffee can device that you sit over top of the actual denture. It just attenuates the X-rays getting at it. So I use Carestream scanners in pretty much all of my scan centers. So what is the tolerance you prefer? So the next question is, what is the tolerance you prefer? So I'm guessing you're talking to me about, you're asking about the tolerance between the sleeves. So generally the sleeve tolerance is 0.1, so 0.1 of a millimeter. So if I had, for instance, a guide tube diameter which was 5, then my guide tubes, the drill that would go into that would be 4.90. So there's a 0.1 sleeve tolerance between the two. Now, I really like the BlueSky Bio sleeves, and I also like the Yastem. And they happen to only make a 5.04 sleeve. So, which it means that my Yastem only has a 0.04 millimeter sleeve tolerance, which is really tight. But it's fine; it works perfectly. But a 0.1 is kind of the norm. Thanks. Why not convert the scan appliance to an immediate load denture? Yeah, that's exactly what I did. So they asked, why not convert the scan appliance to immediate load denture? And that's what that is here in Mesh Mixer. That is the scan appliance here, which all I've done is taken out of BlueSky Bio, and I've just cut holes in it to be exactly in the right position. So now that's my scan appliance, which I'm going to 3D print with the holes. You could use the original scan appliance, but then you would have to manually put the holes in these positions, which would work absolutely fine as well. That would work fine. So are we going to be provided with this case STL for practice? Thanks for your great work. Yeah, I have no issue with providing this for you. Just send me an email and I can send this case over so you can work and play around with it. No problem at all. So next case, Nikhil, hope you're well, my friend. Where are we here? Yes. Do you use hexed multi-unit abutments, and how do you get the position right once the implant's in place? Yeah, great question again. So majority of my cases, I tried to plan parallel, so vertical implants. But obviously bone won't always allow that. And you sometimes have to tilt the distal ones to stay out of anatomical areas. So if we go back to my BlueSky Bioplanning, let me just turn off of the, close that. And let me just turn off the Q&A for a second, or minimize it. So if we go back to the planning here, let's say, for instance, we want to distal angulate these most distal implants here. So I'm going to just unlock this implant, and I'm just going to tilt it backwards. Okay. This is one of the most tricky things in full arch implant dentistry to get right. So here is my distal angulated implant. Now, what I'm going to do is I'm going to change this abutment, and I'm going to replace the abutment for a 30-degree implant abutment, which is common to most multi-units. So most multi-units come in at 17 or 30-degree angulation. So let me just turn this off as well so you can see that now. So there's my bent abutment. Yeah, can you see that? There. Okay. So now what I'm going to do is I'm going to rotate this abutment along the long axis, and I'm going to rotate it so the screw channel is again through my prosthesis. Okay. So there, let's say it's there. So I just rotate that around, and there's my 30-degree bend. Okay. So now what I need to do is I need to control the timing of that implant so that when I've placed it, that I put on my hexed multi-unit, that screw channel is going to be in the right position. Now, there are, if you're using BlueSky Bio, for instance, and their surgical drill kits, they have a way of controlling the timing. The Ostem ones have the same way. And basically inside the kit, as you're winding the implant in, the driver that winds it in, there's a little marker on it to allow you to position the hex in the right spot. But how do you know that this implant is where the hex is on this implant? If you right click and replace the abutment, this is a trick actually, a really good friend of mine, Raymond Ralphie, told me. If you go onto this abutment and you just change it for a, where are we here, abutment, you change it for like a tie base or something. The tie bases have a, let me just find a tie base. Where are you? Yeah, tie bases have an anti-rotational little nipple on it, if you will. Let me just go in here and turn these surfaces off so you can see this a bit better. So if you look here and see there's that little nipple, well, that little nipple corresponds to the flat end of a hex. So if I know that's the flat end of a hex, and I can put then my indicator of my rotational drill as I'm placing the implant to align with that, then I know that my flat end of my multi-unit will sit into that right position. I hope that makes sense. So that little nipple there represents the flat end of a hex. And that means if I've placed this implant and I've drilled down to the right depth and it stopped at this level here, and the rotation is correct, that flat end will be in that right spot, which means my multi-unit will sit in the same spot as well if I put the multi-unit into that position. I hope that makes sense. Okay, more questions? So when you use your frozen to make your surgical guides and temps, what resin are you using? Yep, so I use Nextdent SG for the surgical guides. And I've been playing around with different resins for the temporary prosthesis. I've used the oh, I've forgotten. The first one I was using was GC temp resin. And then I flipped over to using the Nextdent bleach shade temporary crown and bridge material. And what I do is I usually make that to full contour, and then I cut back the gingival area and add on material like Nexico or Gradia gum or something like that to give the gingival portion. Okay. What materials do you use to pick up your temporary cylinders to the PMMA provisional? And do you remove the entire prosthesis to neaten up the polish, the internal surfaces? Yeah. Okay, so when I first started doing this, my height between the temporary prosthesis and the soft tissue wasn't very good. So I had to do a lot more manipulation. Now I do take it off to fill in all the little spaces, but I actually do everything chairside now. I used to use a technician within my lab to do it, but now I don't need to do that because I've dialed things in a little bit to allow me to make this really, really easy. So I use a material to pick up the temporary cylinders. It's called Quick Up, and it's basically just a dual cured composite resin. It comes in 2 different colors. It can come in tooth colored material and also pink material. And it comes in just an applicator. You syringe it out around the multi-units, try to get all the way down to the bottom of the multi-unit and syringe it all the way up. It comes with a nice little, very delicate little applicator to put it down into it. And then once it's all set, I then take it all off. And if there's any areas I need to revise or refill in, I do that. How do you cater for the polymerization shrinkage? Yeah, you can't essentially. But the good thing about this type of pickup is that I'm actually not got that much. I don't have that much. If you can imagine, what I do is this hole is actually 5 millimeters in diameter, and my temporary cylinder is actually 4 millimeters in diameter. That's the tolerance that I'm allowing, which means I don't have a really big thickness of resin between these. So which means my shrinkage, polymerization shrinkage, is going to be far, far less compared to if I had this whole area troughed out and then I was picking them all up with a big bulk of a composite or a big bulk of acrylic, which then can shrink considerably. But then you have to, I guess you have to also consider this. The implant, if the shrinkage is going to occur, does it really matter at this stage? Because the implants aren't integrated yet. So the shrinkage is going to occur, it's going to pull on your implants, and then it's going to relax because your implants actually haven't bonded to the bone. So as the acrylic has relaxed, the integration of the implants is going to occur over the next 3 months. So the shrinkage at this stage doesn't actually matter. Okay, questions again. Where are you? Okay, so are these initially non-engaging abutments? I think I answered that above. I try to, as much as possible, always use straight abutments, which are non-engaging. But if I have to use angled abutments, then they will be engaging, so they'll have a hex on them. Hello, Stefano. What exposure level do you take the CBD scans with? Yeah. So if I don't have a Carestream scanner, I use something to attenuate the scans, or I set it on, sometimes scanners have child settings. So what I've done, if I have a scanner that doesn't have that type of setting, I actually just take a whole series of scans, practice. Just get a denture, put it into the scanner, and take a bunch of scans with it, and then look at them all, and just see what settings give you the best clarity of your denture scan when you scan it. Why do you need to scan the denture again separately outside of the mouth? Yeah. So when I scan the denture again, what I'm doing is I'm creating a DICOM data set of that denture, which will then allow me to convert that into an STL surface, which then will allow me to create a surgical guide. If I don't scan it outside of the patient's mouth, all I'll have is radiographic markers inside the patient with no scan prosthesis that I can convert into a surgical guide. I'll have no surface to be able to create. So you need that dual scan to first orientate the prosthetic envelope to the patient, the soft tissue surface of that scan appliance to the patient, which then will be converted into the surgical guide.
David, how are we doing on your time and your schedule?
I'm fine. I'm fine. So no problem at all. If everyone's happy, I'm happy to carry on.
Okay, perfect.
Yeah. Okay, so I got another question here. I mean, how much, the question is, how much tolerance between the drill diameter and the internal diameter of the sleeve or tube? Yes, and that is 0.1 of a millimeter. So like I was saying before, if I have a guide tube internal diameter of 5, then my drill would be 4.9 to sit inside that. Okay, so the tolerance is generally 0.1 of a millimeter. BlueSky Bio, I think they set it up at the same tolerance. Is that right, Michael?
Yes.
Yeah, it's generally 0.1. Now, like I was saying, I use my Ostem drill with a 5.04 sleeve. So the tolerance is 0.04. So it's even tighter. Now, does it make that much difference? I don't find it makes that much difference. But it just happens to be that I like the BlueSky Bio sleeves. So that's what I use. Okay. Now, another tolerance that you have to think about as well is the tolerance of the sleeve inside the guide. Now, that will really come down to your printing tolerance. Generally, when I'm printing on the frozen, what I do is if I have in my BlueSky Bio setting, I'll set my guide tube setting to be 0.15 bigger than the outside diameter of the guide tube. So let's say, for instance, the outside diameter of my guide tube is 5. Then in my BlueSky Bio setting, I would set it to 5.15. And that will just allow me a little bit of space to be able to bond my tube into the guide. Okay, I hope that's answered that. Do you prefer pilot guide or fully guided, and why? Yeah, great question. So the only time I ever set up a pilot guide generally is if I have very, very narrow spaces. And like, for instance, I'm trying to place upper laterals or lower anteriors. And my guide sleeve just can't fit between the actual physical teeth. Every other case where I can fit a fully guided sleeve into the space, I will plan it fully guided. And I do that for a number of reasons. If I, let's say, for instance, I start my drilling sequence, and always with a fully guided guide, it starts with a small diameter implant, a small diameter drill, which is essentially a pilot drill. So if I have my fully guided guide with my pilot drill with my Ostem, which is 2.2 millimeters, I drill my pilot, and I want to stop and just go freehand, I can. If I have only a pilot drill type of guide, I have to stop at that stage. So if I set it fully guided, I can then continue down the sequence of my fully guided guide to allow me to drill the osteotomy. So classically, how I tend to drill my sites is I start with my initial guide, my fully guided pilot drill. I then take the guide off, or I drill through the guide. I use denture burrs to expand the site. I then put my guide back on, or I already have my guide on, and then I use my final drill in my fully guided kit to finish off the osteotomy. And then I deliver the implant through the guide. That is a real classical way that I prepare my sites. So initial pilot to length, denture burrs, 2.5, 3. Then I go and pick up my final Ostem burr, finish the site, deliver my implant. Okay. Have you noticed fit issues with guides without pins? I just find that with pins, you have to hold things less. So the pins are essentially an extra set of hands, aren't they? So if I was going to do how I would drill my a Fullarch without pins, is I would do this: is I put the surgical guide in position, and I would drill my first site, and I would keep that my hand on, and I'd walk all the way around. And then what I would most likely do is I'd go back to my very first pin site, and I'd actually put the burr back into the guide and then let that act like a pin, and then go back and do my other sites, just to help keep that stable if I haven't created my own pins. So you can use the burrs themselves as pins inside the osteotomy holes. That makes sense. So let's say, for instance, I've got 6 implants I'm going to place. I put the guide on, I drill my first sites, all of them. I go back and place that drill back into a couple of the sites. And then I go back and drill the rest of them, just to help position. If you're drilling where the guides become most unstable is in the lower arch. You have a very minimal amount of ridge in the lower arch. Well, anything down there, the denture was sloppy, the surgical guide's going to be sloppy as well. Okay. The pins don't, I guess the key take home there is the pins don't make the accuracy of the guide. The pins just help retain it once the guide has been accurately seated. I think that's the key there. Dual scan question. How do you scan just the denture? I mean, any suggestions? How do you stabilize? Oh, stabilize it. Yeah. So how do you stabilize the denture itself on the scan, in the scanner? So most scanners have like a little plate that you sit them on, actually a little plate, and then a little bit of foam that you sit the denture on top of. I've been in surgeries where I just physically take the denture and actually taped it onto the bite fork, or anything just to position it in the right position. But most scanners, most modern day scanners, will have a little plate that you can then just set the denture on top of, and it will scan it. And that's actually quite important, because the plate, you want it to be not radio opaque, because if it's radio opaque, it will pick up that bit and it might obscure the fitting surface of the denture. So you need to sit on something that's relatively radiolucent. So like some tissue or something that's on there if you don't have the little bit of foam. Okay. Another question here. Are you aware of any implant courses for CDTs, either post-grad or CPD? Implant courses as in to do, maybe Paul, I'll ask you a question back and you can ask me again. Is this to do like the immediate conversions, or to learn how to do the restoration on implants? Go ahead, you can ask me again. Can you explain the stages of temporary prosthesis used before the final prosthesis in Fullarch cases? Yeah, okay. Great question. So as my evolution of how I convert these Fullarch cases into the final restoration, I've kind of tried to minimize the amount of surgery time, but then get the maximum amount of data to my technicians. So what my sequence workflow is now is I do this. So surgery and immediate load prosthesis goes on, which is based on a smile design prosthetic of the patient. That's getting me about 60% of the way of where I want the final tooth position, maybe more, 60 to 80% there. At about a month and a half, maybe about month and a half to 2 month mark, I then get the patient back in. I take a soft tissue reline underneath the immediate load prosthesis. I then take an occlusal registration. I take everything off and I go downstairs and I pour my master model from that. And what that'll do is it will give me a implant position, which has essentially a Duralay jig on it, but it is a Duralay jig that's been on the patient during the entire integration phase, which means that there can be essentially no more passive restoration than that one. Because what will have happened, as someone said earlier, is that there will be shrinkage, there'll be movement, there'll be whatever. And what will happen is those implants and the prosthesis, if they're held together still with the screws, if the screws are still on it, the implants will have integrated, and that restoration will have still been sitting in position. So the implants, if it was tight, will have moved into that bridge, if you will. They'll have come together. So now I've got that beautiful restoration that's completely passive on those implants. I've got a new soft tissue, which I've taken with a reline of light body silicone. I have an occlusal registration. I take all of that downstairs, I pour models, my master model, and I articulate that. I also take DSD photos of the patient with that prosthesis in place. So now I can relay all that information to the lab. And the lab will have now a physical scanned prosthesis that they can scan immediately. They'll have articulated models in the right vertical dimension. If it's not in the right vertical dimension, I change it by adding wax or reducing, whatever. And the next stage is I then go back to the patient with a 3D printed try-in. I print 2 of them. And the purpose of this is with the modifications I want to make in this next restoration, this next temporary, that isn't quite there yet. I want this next temporary to be 99% there. So I give this 3D printed trial version to the patient, and I then take my next set of photos, and I look at those photos, and we look at them together, and we say, okay, maybe we need to shave this, maybe we need to shave that, maybe we need more length. Whatever we do, we need to do to it. And I do it to one of them. I do the same to the other, but I leave one of them with the patients, and I take the other one back to the lab. So they have a physical, something that's physically been into the actual patient that's had the modifications to it. And why I do it this way is, the traditional way of doing it is you set up denture teeth and you try the denture teeth in. But what I found is that my patients then say, well, you tried something in that looked like denture teeth, but then you gave me something else in my final restoration that doesn't actually look like denture teeth, unless you're converting it into an actual hybrid prosthesis. And I don't do a lot of hybrid prostheses anymore. I tend to do composite wraps on metal, or like a BDT type bridge with thimbles and individual crowns on it, something like that. I don't tend to do bars with acrylic wrap on them anymore. So once I've got that that prosthesis that the patient exactly likes, and I've made a copy of it with the two 3D printed versions, that then gets invested into a silicone matrix, which is then frame is made within that, and then composite is wrapped on top of that. And the final prosthesis that comes from that is exactly the same as the 3D printed try-in. The shapes are exactly the same because it's been made from the essential scaffold that the patient has had in their mouth. That's a relatively quick walkthrough of that. Okay, how do you do the bone segmentation yourself or delegate to BlueSky Bio? How much time does it take you to do this? Yeah, okay. So the bone segmentation is a process. The amount of time it takes is relative to how, like I was saying earlier, how well the bone is formed. The mandible will take me probably 10 minutes to do. The maxilla might take me 20 minutes, maybe a little bit longer. So there are services out there that will segment for you for a fee. You can always send it through to us. We can segment it for you. It doesn't really matter. But yes, there is a time element associated with segmentation. If I've got some time, I'll do it. If not, then I'll outsource it as well. Can you explain? Okay, I think I did that. Yeah, I did that one. Okay. How do you add the screw holes for fixation on the BSB, on the surgical guide interim appliance? How do you add the screw holes for fixation on BSB, on the surgical guide? Oh, do you mean the pin placement holes? If it's the pin placement holes, you do it this way. So you've just like you add any implants, you will simply go into the add implant area, and there's a little pin one, And this is a BlueSky Bioplan, which comes with specific drills to drill this. So you add this pin just like you add an implant. So where is it? Sorry, let's do that again. Grab it. So it's on the edge of my pointer. And what I'm doing now is I'm just going to grab this, and this is a physical pin, a BlueSky Bio pin. And now that that pin's in position, when I create my surgical guide with a guide tube associated with that pin, it will create the hole in that prosthesis to allow me to pin it in position. Does that make sense? Okay. Next question. When using a tissue-borne guide, do you always raise a flap as well to verify accuracy of alignment? Yeah. Good question. So do I always open a flap? No, not every single time. I would say 99% of the time I do. The times that I don't do it, all the moons have to have lined. There has to be enough band of keratinized tissue. The bone has to be wide enough so that I have 2 millimeters of bone on either side of that implant. The number of cases where all those things come together are very far and few. You know, there's not very many of them. So I would say that most of the time I'm raising a flap to verify and or to graft after. So yeah, I would say it's not very often that I'm not raising a flap on these cases. Okay. Next question is, what is the accuracy of implant placing using surgical guides compared to analog? I get this question quite often, actually. So placing an implant analog, well, how can you determine the accuracy of that? Because all you're doing is you're opening a flap and looking, okay, I'm going to stick an implant here. Well, that, in my mind, has no reference to where you want the future tooth to be unless you have some type of surgical guide in there. Now, if you look at the data on surgical guide placement, implants placed with surgical guides, they generally look at three things. They look at point of entry of the implant into the bone. They look at the angle of the implant at the apex after it's been placed, and then the angle of deviation between the two. And generally, there's kind of a range, and that range can be anywhere 0.57, if I remember the data correct, up to 6 millimeters, with an average of about 1.25 millimeters at the point of entry. The apex, again, is about the same, so 0.5 millimeters to about 6 millimeters, with an average of about 1.25 millimeters, and an angle of deviation of 3 to 4 degrees. So that's kind of what the science says about the accuracy. What I find in working in my own hand is I find that these surgical guides are extremely accurate. And it's hard to tell because I'm not then scanning the patient and then overlaying the data of my plan to what I actually did. So I don't know, but I do know that when I plan the case and I want it to be just anterior to the anterior wall of the sinus, and I go in there, my surgical guide is completely obscuring my view. I drill that osteotomy, I take my X-ray, and it's exactly where I wanted it to be. Now, it doesn't happen like that every single time. And if anyone that is let's say, guru of guided surgery says that it happens every time, they're lying. I've had many cases where I planned my surgery with my guides, and it's not quite going the way I want it to. And I stop, I put the surgical guides down, I do everything analog. And that is just the reality of guided surgery. Okay. What's the best way to eliminate scatter when taking a scan? Yeah. So the good news about scatter is generally, the first thing is it generally runs parallel with the beam. So if you look at a lot of the restorations or things that create scatter, they're usually sitting within the tooth, which means that we usually have cusped tips that we can align the actual STL surface to the DICOM with. And that can also correspond with metal ceramic restorations. Usually the metal sits underneath the porcelain, And the porcelain cusp tips or the incisal edges come up really clear in the DICOM data. Some scanners are better at reducing scatter. They have like an automatic scatter reduction algorithm within them. So I tend to find that the newer scanners are better than the older scanners at reducing scatter, but there's no physical way that you can actually do that. It's just what your scanner is doing, how it's picking this stuff up, and the algorithm that it has in it to reduce the scatter for you. Okay. Next question. The final prosthetic design for the case that you showed with the 4 implants on the lower was a zirconia hybrid. Do you use bars or overdentures or bar acrylic or trilure? So I have done every restoration that you could possibly think of except trilure. I've never done a trilure bridge, but I've done Fullarch zirconia, monolithic, buccal cutbacks with porcelain layered on zirconia. I've done 3D printed bars with acrylic wrap. I've done casted bars with acrylic wrap. I've done titanium bars milled with acrylic wrap. Titanium bars with thimbles on top. I've done composite with metal substructure, titanium, cobalt chrome, whatever. The restoration that like I said, I've gone back to again is I've gone back to a titanium frame or some type of metal frame with a composite wrap around it. And why I've done it that way is I like the predictability of being able to deliver the patient that 3D printed temporary prosthesis and have a duplicate of it, and then be able to invest the duplicate into my silicone matrix so that the patient who signed off on my temporary prosthesis is getting the final thing exactly the same. The tooth position's the same, everything is the same. The only difference is it's going to be livelier because it's in composite rather than 3D printed material. Okay, what drills do you use? I use I've got all kinds of kits. I've got an Astra fully guided kit, which is keys. I've got an Ostem old kit, which is keys as well. I've got an Ostem one guide kit, which is a kit I use currently, which has a key incorporated into it. BlueSky Bio do a very, very nice keyless kit. It's very, very similar to my Ostem kit. In fact, it's probably slightly simplified. But yeah, those are the drills I tend to use. Next question. Does BlueSky Bio provide all sleeves or do you purchase from original suppliers? Yeah, so BlueSky Bio provide, they have a whole array of sleeves of different sizes, dimensions, different internal dimensions. So again, this is another feature of BlueSky Bio that I love. If you have a surgical kit that you're using, I can figure out a way to make a guide for it. There's not many softwares that you can do that with. So I can manipulate the offsets, I can manipulate the guide tube dimensions, whatever way that you need to create a guide relative to your surgical guide. So sometimes I get dentists from all over the world that send cases through. And they say, David, okay, I don't really know any of the dimensions of my guide, but can you set me up a guide for this? And I say, no problem. Just go and measure your drill. Measure the diameter, measure the length of it, and then tell me those dimensions. And once I know that, then I can start designing the guide based on those dimensions. Okay. Scott Wilson. Oh, wait. Oh, yes. You can also provide, we also buy sleeves as well, going back to Wayne Jenkins' question. We also buy sleeves from the original. So let's say, for instance, BioHorizon. They have specific sleeves associated with their guided kit. We buy BioHorizon sleeves. Another nice thing about that is if you placed, let's say, for instance, let's just change this implant around for BioHorizon. Let's say a Noble Active, and then let's do a Straumann bone level. Let's just say I put that Straumann bone level in. What happens up here is it brings up the guided surgery kit for that. So then you can use you can use the kit. It's already pre-programmed in there for you to allow, and it'll create the offsets and everything for you to allow that, I say, sleeve to sit into it and your drills to work appropriately for that guide. So it takes a little bit of the guessing out of it. I always check it again. So I go back, I know the dimensions of my guided kit. I go back to the guide tube settings and I just recheck and recheck, because you're responsible for the surgery, right? Okay. So next question, where are we? Q&A. So, okay, you mentioned placing, Scott Wilson, you mentioned placing radiographic markers on the fitting surface of the denture around the incisive canal in upper sevens and taking scan in situ. How do you, oh, I do it on, excuse me, I do it only on the non-fitting surface. So just on the outside surface. So I put them on the buccal flanges of the 642, 246, and then on the palatal surface, not on the fitting surface, 7 incisive, midline 7. Oh, can you please tell me your email again? Yes, I'll do this. This might be easier if I just open this. I'll just do this and write it on here so everyone can get a copy of it if they can see this. So I'm going to give you actually Rebecca at Smile Design. She's is my logistics at the lab. So everything goes through her. So that's Rebecca's email. Excuse me, sorry. So you can email her and everything will go through her. If you have any questions about anything, it'll come through to me. Philippi, do you intraoral sedate your patients on this kind of case? What do you prescribe? Yeah, so I would say 90% of my surgeries, I actually don't do any sedation. I've kind of gotten it to a kind of a slick little orchestrated procedure. So I find that I don't often need sedation for it. If there's going to be, I obviously every patient's different. You know, you have to gauge the patient. But that, like for instance, that case that I showed you with the bone reduction, the patient wasn't sedated for that. It was just under local anesthetic. Now, if I was going to sedate the patient, my preference would be IV sedation. And what I do is I have a sedationist come in and do the sedation for me. And again, they use midazolam for that. Okay. David Diamond, do you advocate same method in the maxilla? Bone is softer, etc. Do you submerge implants and do uncover later, or do immediate load again? Which is better, mandible bone, very difficult, than maxilla? Okay, so this is a question essentially of, is it appropriate to do immediate loads on the maxilla or the mandible or whatever? Yes, bone is different in each arch. I find if I have really soft bone in the maxilla, I just underprepare the osteotomies and then allow the implants to kind of produce the osteotomy for me. So for instance, let's say I'm placing a 4mm implant. I might only drill that site in the maxilla to like a 2.2 or a 2.5, and then let the implant actually cut its way and create the site itself. And it will do two things. It's going to expand and push the bone, hopefully compacting it and creating a greater density. And you're going to get much better primary fixation of the implant. One thing you just have to be really careful of is that you don't provide so much pressure that you create a pressure necrosis in the bone, which will then reduce your integration rate. So what I do is, as I introduce the implant, I introduce the implant and then back it out. I introduce the implant and then back it out. Introduce the implant and then back it out. And I'm expanding and contracting, and expanding and allowing the bone to be manipulated around the implant. And then once I get the implant down into my final position, I then torque it down and make sure I reach a certain torque level. And you know, I actually never actually look at the torque level anymore. It's all from feel. I just know how it feels. If it feels right, then I know I'm able to load it. So this, again, people always say there's a certain torque. You've got to reach a 40 Newton torque. You've got to reach this. I just kind of feel it just from doing a lot of these type of cases. Okay. For these angled abutments, how do you deal with bone on the nail? Yeah, great question. So what I tend to do is a couple of kits have very nice little, they're kind of like profilers that you place something inside the implant, and then a burr sits over top of that and channels down that guide, which then profiles the bone on the distal. What I do, I don't have one of those, is I put a 2mm healing cap on, and then I take a round burr and smooth the bone off on the distal. That's how I deal with the distal portion of the bone. Okay, or a cover screw or something to protect the head of the implant from my burr, and just be very careful. Dennis Lee, just to confirm, the 2 scans needed for the dual scan technique is the CBC of the patient with the prosthesis in, placed with the glass radiographic markers, and an SDL of the prosthesis itself. No. So the dual scan technique is you need, the patient will have the denture with the radiographic markers in their mouth. You'll go and put them in the scanner. First scan, CT scan. Then you'll take the denture itself and put it in the CT scanner as well. Scan the denture. Now you have 2 sets of DICOM data. The SDL is only then created in the BlueSky Bioplan when you convert that DICOM data of the scan appliance to an SDL surface. Okay, so no SDL, no scan of the denture. It has to be a cone beam CT scan of the denture itself. Okay, so next question, immediate load not cleared for me. Can you repeat it, please? Okay, immediate load. So once the implants are placed, again, I plan my prosthesis, I plan my implants. I then take my prosthesis out of the BlueSky Bio. I delete out of the abutments, which are going to be in the right positions of my implants. I put on my multi-unit abutments onto the implants, and then I put my temporary cylinders. A temporary cylinder is basically just a temporary tube which screws into the multi-unit abutments. I then put over my temporary prosthesis onto the titanium cylinders, and I bond it on with a resin. I then take that off. I trim all the excess resin away, trim all the excess temporary away that I don't want, close my surgical site, and then deliver the temporary immediate load. Or close the surgical site before the pickup, whatever way, just as long as the surgical site is closed first. Okay. Thank you for your nice, another question. Thank you for your nice and knowledgeable presentation. If I may ask a couple questions. What type of material have you used for your final restorations? Are you with less implants and distal cantilever or pterygoids and zygomatics? Yeah. Okay. So I think I answered the question on what type of materials I've used already. My thinking on cantilevers. Yeah. So my preference is, if I can, to have vertical implants. If I can't, okay, I guess the first question is, how many teeth are you restoring? If you're generally only restoring to the second premolar, you don't, most of the time, you don't need to distal angulate those last implants. You can vertically position them and have a small cantilever. That's fine. If you are planning to go more distal than that, most likely you're going to have to distal angulate the implant if you want to stay in anterior to the mental foramens or anterior to the anterior portion of the sinus. Now, if you physically look at the distal angulation and the amount of increased cantilever or reduction in cantilever compared to a vertically placed implant, it's not that much. maybe one tooth position, one premolar. So in my looking at my cases, I find that placing the implant vertical makes restoring it that much easier, makes the immediate load that much easier, and doesn't give me that much more benefit if I distal angulate it by one premolar. Now, if I'm going to restore to the 6s or the 7s, which is very rare, then I would consider a pterygoid. And pterygoid implants are a way of getting around that cantilever. The other alternative is to do a bilateral sinus lift and place implants in your 6s. Again, I place them vertically as well. I think the underlying, my underlying feeling is, or the way I tend to treat people is, I tend to try to place them as vertical as possible. Okay, are you using the one guide drills? Thought these drills do not have sleeves. Yes, they don't have sleeves. That's from Richard. So you can drill with the one guides drill directly into the plastic. I've done cases like that, many cases like that. I tend to like to have the metal sleeve and then to drill into that. I just like the added accuracy of the two metal sleeves, the drill sleeve and the metal sleeve itself. That's the only reason, but they're perfectly fine to drill directly into the plastic. Do you use any bite next question. Do you use any bite registration material between the upper and lower dentures during your cone beam CT scan? Yeah, good question. I would do that only if the patient doesn't have a very nice interdigitation. If they have a very flat occlusal plane posteriorly, then I would use a bite registration so that when my surgical guides are created, that same bite registration will allow me to position the two surgical guides in the right spot so that I can pin them into position. So it's like a silicone key, which is the same silicone key was used at the time of the CT scan, which will then be used at the same time as the surgical guide positioning. Okay, next question. How do you, I don't know, treat the holes in the model to create the temporary prosthesis in mesh mixer? How do you create the holes? Just like I said, you'll have to go back. I don't think there's enough time today, but there's a method of Boolean subtracting the abutments from the actual denture. So you have to go back and have a read through it.
Okay, I think now that we're wrapping up another hour, maybe pick another 2 questions.
Okay, yeah. It's been an hour, Jesus.
Yeah.
Okay, sure. Do you not put in lingual or palatal pins? I essentially put pins in any position I have good bone. It doesn't matter where they are. I like palatal pins in the upper arch, and I like buccal pins in the lower arch for obvious reasons. I'm trying to stay away from key anatomical landmarks, particularly the lingual artery in the lower arch. Let's see here.
Okay, maybe one more.
Yeah, sure. Try to pick a relatively straightforward one. We got some. Okay, is there any benefit to a pre-scan reline of an approved removable restoration with radiographic material such as Blue Moose? So that's from Paul Springs. Is there any benefit to a pre-scan reline of an approved removable restoration with a radiopaque material such as Blue Moose fixed with fit checker set retardant? Okay, so basically you're asking, is it a good idea to reline the prosthesis with some type of radiographic material? And my question to that would be no, because what we want to do is, yes, reline the prosthesis, but the radiographic material needs to be in the beads, not in the palatal bit, because we need specific spots to pick, not a whole palette. The software won't be able to orientate the two DICOM datas when there's such a mass of radiopaque material. So reline the soft palette, reline the denture with a light body silicone a hard acrylic, whatever, to get that nice fit, but don't use a radio opaque material because it'll obscure the radiographic markers. Oh, that was 2 hours of fun, eh? Yeah, coronavirus fun.
There's still a lineup of questions that keep getting longer and longer.
Hey, I guess that's, I don't know, if is that a good thing that I didn't answer all, you didn't get enough out of the presentation, or it's such a big subject that we could go on forever here? You know,
I think it's a tremendous subject, and I think it shows everybody's interest and everybody's interest in getting your feedback and opinion and education. So I think that shows the quality of the speaker and the webinar.
Oh, great. Thank you. Appreciate it.
Thank you very much. Thanks for presenting. Do you want to put your email back up, or is that too dangerous?
Yeah, I will do that. Yep. Where are we here? Make that a bigger for you guys.
Okay, so that's a very generous offer there that David's showing an email address. You could contact him with questions.
That's not my false identity or anything. My name isn't Rebecca in the evenings. It's David all the time.
Well, David, thank you very much for taking the time and for sharing and educating and presenting. Very much appreciated.
Pleasure, guys. Everyone stay safe, and hopefully see you on the other side of this, eh?
Yep. We hope everyone returns to their routine pretty quickly, and of course with more education and more tools that they have available. And I'd like to thank everybody for attending the presentation, and we hope to see you at upcoming webinar presentations as well. We'll be sending the CE, just to repeat, we'll be sending the CE via email to everybody who's watching live within a week or two. And if you're watching the recording, then complete the 10-question multiple choice test, and we'll be able to send you a CE credit for that. So thanks for attending, and we hope to see you at future presentations. And David, thanks again. Thank you so much.
Thank you, Michael. Nice talking to you. Bye now.
Okay. Bye-bye.